Hi, in today's video, I'll be talking about hyperglycemic crisis in adults and the updated version of the American Diabetes Association consensus report on the diagnosis and treatment of hyperglycemic crisis. Hyperglycemic crisis consists of diabetic ketoacidosis and hyperglycemic hyperosmolar state, the two most severe hyperglycemic emergencies noted in patients with diabetes who are admitted to the hospital. The first consensus report by the American Diabetes Association was published in 2001 and was subsequently updated in 2009. The key points in the new consensus report: it incorporates quantitative beta-hydroxybutyrate measurement into the diagnostic criteria for diabetic ketoacidosis and hyperglycemic hyperosmolar state, and also recommends its use when assessing the severity and determining the resolution of DKA. Managing mild and uncomplicated moderate diabetic ketoacidosis can be done with subcutaneous insulin in a non-critical care setting. Treatment pathways for diabetic ketoacidosis and hyperglycemic hyperosmolar state is simplified into three main areas, which include IV fluids, IV insulin, and potassium. The new report provides resolution criteria for hyperglycemic hyperosmolar state, updated the resolution criteria for diabetic ketoacidosis, and emphasized the use of clinical judgment when making management decisions. Changes in diagnostic criteria for diabetic ketoacidosis between 2009 consensus report and 2024 consensus report. In the diagnostic criteria, D stands for plasma glucose, which was defined as glucose greater than 250 milligrams per deciliter in the 2009 report. In the 2024 report, it has been changed to glucose greater than 200 milligrams per deciliter or history of diabetes and irrespective of the glucose value. K stands for ketosis. In the 2009 report, it was defined as positive serum ketones or urine ketones. In the 2024 report, it is defined as beta-hydroxybutyrate level greater than 3 millimoles per liter or urine ketones greater than 2 plus. A stands for metabolic acidosis. In the 2009 report, it was defined as pH less than 7.3, bicarbonate less than 18 millimoles per liter, and anionic gap greater than 10. In the 2024 report, it is defined as pH less than 7.3 with or without bicarbonate level less than 18 millimoles per liter. Anionic gap was removed as a diagnostic criteria. Changes in the diagnostic criteria for hyperglycemic hyperosmolar state between the 2009 consensus report and 2024 consensus report. Diagnostic criteria. For hyperglycemia, it was defined as plasma glucose greater than 600 milligrams per deciliter, both in the 2009 consensus report and 2024 consensus report. Hyperosmolality is defined as calculated effective serum osmolality greater than 320 milliosmolar per kg in the 2009 report, whereas in the 2024 report, the calculated effective serum osmolality is greater than 300 milliosmolar per kg or total calculated serum osmolality greater than 320 milliosmolar per kg. Effective osmolality is calculated as 2 times sodium in millimoles per liter plus glucose in millimoles per liter. Total osmolality is calculated as 2 times sodium in millimoles per liter plus glucose in millimoles per liter plus urea in millimoles per liter. Absence of significant ketosis was defined as small amount of serum and urine ketones in the 2009 report, whereas in the 2024 report it is defined as beta-hydroxybutyrate level less than 3 millimoles per liter or urine ketones less than 2 plus. For absence of acidosis, in the 2009 report it was defined as pH greater than 7.3, bicarbonate greater than 18 millimoles per liter, whereas in the 2024 consensus report it is defined as pH greater than 7.3 and bicarbonate greater than 15 millimoles per liter. For mental status, in 2009 consensus report, it was defined as stupor or coma, whereas in 2024, the mental status criteria was removed. Main changes to the treatment recommendations between 2009 consensus report and 2024 consensus report. IV fluids, type of fluids. In the 2009 report, it was recommended to give isotonic saline during the first 1 hour. Subsequently use 0.45% saline if serum sodium is high, or to continue with 0.9% saline if serum sodium is low. Change to dextrose 5% with 0.45% saline when the glucose reaches 200 milligrams per deciliter deciliter in diabetic ketoacidosis and 300 milligrams per deciliter in hyperglycemic hyperosmolar state. In the 2024 consensus report, it is recommended to either use isotonic saline or balanced crystalloid solution as the initial choice, with subsequent choice of fluids depending on the fluid balance and sodium concentration. 0.45% saline is indicated only if osmolality is not declining in hyperglycemic hyperosmolar state despite adequate fluid resuscitation. Add dextrose 5% or 10% to normal saline when glucose reaches less than 250 milligrams per deciliter for both diabetic ketoacidosis and hyperglycemic hyperosmolar state. Volume of fluids. In the 2009 report, it was recommended to give 15 to 20 ml per kg per hour or 1 to 1.5 liter in the first 1 hour and subsequently run the IV fluids at a rate of 250 ml to 500 ml per hour. In the 2024 consensus report, it is recommended to give 500 to 1000 ml per hour during the first 2 to 4 hours and subsequently rate can be adjusted as clinically appropriate. Insulin. As per the 2009 consensus report, the initial insulin dose for both diabetic ketoacidosis and hyperglycemic hyperosmolar state was 0.1 units per kg as a bolus, followed by fixed rate insulin infusion at 0.1 units per kg per hour. In the 2024 consensus report, for moderate and severe diabetic ketoacidosis, the fixed rate insulin infusion is supposed to be at 0.1 units per kg per hour or a nurse-driven insulin infusion protocol. For mild and moderate diabetic ketoacidosis, it is recommended to use subcutaneous rapid-acting insulin at a dose of 0.1 units per kg every 1 hour. For hyperglycemic hyperosmolar state, fixed rate insulin infusion to be given at 0.05 units per kg per hour. If there is a mixed picture of diabetic ketoacidosis and hyperglycemic hyperosmolar state, one should treat it as a DKA. Infusion. The initial glucose goal to initiate dextrose infusion as per the 2009 consensus report, the blood glucose to be less than 200 milligrams per deciliter for diabetic ketoacidosis and blood glucose less than 300 milligrams per deciliter for hyperglycemic hyperosmolar state. Whereas in the 2024 consensus report, the blood glucose has to be less than 250 milligrams per deciliter for both diabetic ketoacidosis and hyperglycemic hyperosmolar state. The final glucose goal until resolution in a 2009 consensus report, it was between 150 to 200 milligrams per deciliter for diabetic ketoacidosis and between 200 to 300 milligrams per deciliter for hyperglycemic hyperosmolar state. In the 2024 consensus report, the blood glucose goal for diabetic ketoacidosis is between 150 to 200 milligrams per deciliter and for hyperglycemic hyperosmolar state, it is between 200 to 250 milligrams per deciliter. Potassium management. In the 2009 consensus report, serum potassium was considered to be low if it was less than 3.3 millimoles per liter, and it was recommended to give 20 to 30 millimoles per hour and postpone insulin therapy until the serum potassium was greater than 3.3 millimoles per liter. It was considered to be normal if serum potassium was 3.3 to 5.2 millimoles per liter, and it was recommended to give 20 to 30 millimoles in each liter of IV fluids to maintain the serum potassium between 4 to 5 millimoles per liter. It is considered to be high if the serum potassium is greater than 5.2 millimoles per liter, and one should not give potassium but check serum potassium every 2 hours. In the 2024 consensus report, it was considered to be low if the serum potassium is less than 3.5 millimoles per liter and recommended to give 10 to 20 millimoles per hour and postpone insulin therapy until the serum potassium is greater than 3.5 millimoles per liter. It was considered to be normal if the potassium was between 3.5 to 5 millimoles per liter and recommended to give 10 to 20 millimoles in each liter of IV fluid to maintain the serum potassium between 4 to 5 millimoles per liter. It is considered high if the serum potassium is greater than 5 millimoles per liter, and one should not give potassium but check the serum potassium every 2 hours. 2024 consensus report criteria for the resolution of diabetic ketoacidosis and hyperglycemic hyperosmolar state. For diabetic ketoacidosis, plasma beta hydroxybutyrate level should be less than 0.6 millimoles per liter and venous pH greater than 7.3 or bicarbonate greater than 18 millimoles per liter. For hyperglycemic hyperosmolar state, serum osmolality should be less than 300 milliosmolar per kg and blood glucose less than 250 milligrams per deciliter and urine output greater than 0.5 ml per kg per hour and improvement in cognitive status. Thank you.